surgery. So welcome everybody. I'm particularly happy to say that as hematologist we are opening new collaborations in the area of advanced therapeutic medicine products in the area of these cancers, and you will hear something later. So welcome again, and have a good day.
Thank you, Fabio, and welcome as well. Welcome, everyone. I am Francesco Montorsi, Chief of Urology here. Without further ado, we should start with the first scientific session, Key Advances in GU Tumors. What have we learned in the last year? And please, Andrea, Alberto, come over here and take the lead. We have three very interesting talks covering the entire area. Andrea, please have a seat here. And I think, Alberto, you're going to be the first?
Yes.
So Professor Briganti does not need any introduction. He was a medical student with us at this university, then a resident, then a fellow, then a staff member, now full professor of urology at this university, and last but not least, editor-in-chief of European Urology since a few months. So Albi, please, the floor is yours.
So thank you very much. Good morning, everybody, and thanks for all of you, to all of you for being here with us today in this unique event for us. So I have been asked to summarize the evidence beyond prostate cancer publications over the last year or so. These are my disclosures. So it's difficult to summarize what happened in the last year in prostate cancer. So many publications have been out. But I'll try to pick up those which actually might be practice changing for us. And actually, we all know that prostate cancer has highly heterogeneous outcomes and behaviors. And this, of course, depends on whether the disease is upfront metastatic or whether it's progressing toward metastatic disease. But the major two subtopics I will focus on is early anticipated therapies. And we are in the era of intensification treatments, and now we are using that earlier in the disease stage. And we are also optimized in use of imaging, not only MRI, but also functional imaging like PSMA PET in early disease stages. So let's start for screening. What do we know about screening? There is a huge controversy about prostate cancer screening, but what we have learned is that we do need to do better screening, not only PSA, but also imaging potentially to be integrated. And in this context, MRI has been tested, and we know that the use of MRI plus targeted and systematic biopsy can indeed decrease the number of clinical insignificant prostate cancer which are detected. And the prompt to biopsy or to further screening for prostate cancer might be even higher or better if we use MRI rather than PSA alone. And this has been a recent publication that came out on New England Journal of Medicine, where there was a randomized trial, which is the Godepon 2, with randomized patients to either PSA targeted screening plus MRI and biopsy regardless of MRI results, or targeted biopsy only in case of positive MRI. And the idea is indeed to decrease the number of systematic biopsy we perform nowadays and to focus only on target biopsy, at least for diagnostic purposes. And this is a positive study in the sense that those patients randomized to PSA and MRI plus targeted biopsy only had lower rates of clinical insignificant prostate cancer detected. The number of clinically significant prostate cancer was instead kind of similar between the two groups. So food for thoughts and integration for MRI in our algorithms for prostate cancer screening. And we do yet need more evidence, and we are all eager to await for the results of the PRO-based study, which is the first one that is including a sort of MRI as a triage test for further screening in patients according to baseline risks. The outcomes and the results are not there yet, but it will be ready in a couple of years or so. What about diagnosis and treatment? Well, I just will point out, this is not a prospective randomized study, but this is a study that we accepted European Urology a couple of years ago that for the first time used PSMA PET as a diagnostic tool for prostate cancer. Does it make sense? We do not know. Is it cost effective? Australians say yes, but we do not yet in Europe. But the main endpoint here is that we can increase the sensitivity of MRI for clinically significant prostate cancer if we put PSMA PET on top. Food for thoughts, PSMA PET is here to stay in all disease stages, maybe also in the diagnostic phase of the disease. So what about the PROTECT study? This, I think, is a landmark study in terms of treatment, which came out this year in New England Journal of Medicine, and it is reiterated something which we knew already. So if we randomize patients to radiation therapy or surgery or active monitoring, there's actually no difference in outcomes in terms of survival. But the 15 years outcomes of this study show that there is instead a difference in metastatic progression and local progression. Why is this not translating to higher rates of survival for those treated with radiation therapy or surgery? We do not know yet, but there is certainly an issue here because the vast majority of patients, including in this study, were actually having either low or intermediate risk. So we are biased towards treatment given to patients who are less likely to die for prostate cancer. And there is indeed a prospective randomized study, which is SPCG-15, which is currently ongoing in the Scandinavian countries, which is randomizing patients to radical prostatectomy versus radiation therapy in the high-risk setting, which is the setting we care more about in terms of outcomes and patient management. But what we have learned over the last year is that treatment intensification, even in the earlier disease stages, is making a difference. Is now indeed, as you know, we are kind of killed by all pharma companies coming to us as urologists or radiation therapy, say, why don't we test this? We do it early, we intensify. Maybe we then switch to another treatment or stop the treatment, but at least we intensify upfront. And then the intensification therapy works in localized disease. The answer is yes, provided that, again, you pick up the right patient population. Like this one, and this is another great STAMPEDE contribution that randomized patients with either radiation therapy plus ADT or a combination of radiation therapy plus ADT plus 2 years of abiraterone. And they picked up, of course, patients with high-risk prostate cancer, not yet metastatized, patients with either clinical N1 disease or very high-risk disease. And the bottom line of this study is that combination therapy like radiation therapy plus 2 years of abiraterone plus 3 years of ADT is indeed improving patient outcomes in a significant way. And this has been indeed recently included by EU guidelines, which recommend the use in clinical node-positive disease, radiation therapy plus 2 years of ADT plus 2 years 3 years of ADT plus 2 years of abiraterone. Whether surgery is playing a role in the setting of CN1 disease needs yet to be elucidated, but is still contemplated as a possible treatment option. So what about biochemical recurrence? And surgeon, we always make jokes among us saying, well, sooner or later, all patients with prostate cancer will recur, right? It's a matter of understanding which recurrence is clinically meaningful and which recurrence can be easily observed. And this, indeed, is a major focus of current research. What we also have learned over the last years or so is that there is no need to define any longer biochemical recurrence in terms of cutoffs, whether it's 0.2, 0.4 after surgery. It doesn't make a great difference, provided that you have further ways to stratify these patients, like PSA doubling time or even PSMA PET. But again, I think we cannot ignore the results of the recently published EMBARK study, which is the very first one that is applying the idea of treatment intensifications in patients recurring after either surgery or radiation therapy or a combination of both. Again, we should be very careful here because we are not talking about early recurrences in patients treated with surgery. Indeed, inclusion criteria included patients with PSA higher than 1, which is late recurrence, honestly. But still, these patients were randomized to ADT plus enzalutamide or ADT or enzalutamide alone, or again, a placebo plus ADT. So it's 3 arms with the main endpoint being metastasis-free survival. The study is positive. So if we do a combination therapy, if we intensify treatments in patients with recurrent disease after surgery, picking up the right patient population, we are indeed improving patient outcomes. And this is clear from the EMBARK study. However, we do not know the role of PSMA PET in these patients because these are all negative at conventional imaging. And I mean, honestly, nobody is scanned any longer after surgery with conventional imaging. We only use PSMA PET. So is this applicable nowadays? Not sure, but definitely great evidence and phase 3 study. So what about the intensified approach for metastatic hormone-sensitive disease? This is another chapter that has been studied over the last year, and we actually understood that the more drugs you give in a very easily way, the better it is for some patients. And we need to identify which patients indeed need really treatment-intensified approaches. But again, the results of the ARA-Sensor, the PEACE-1 study has really are going that direction, right? So intensification with triple therapy is indeed making a difference in terms of overall survival benefits, even though we still need to understand which category of patients benefit the most from it. And of course, we are coming up with this division or classification into high and low volume disease. And it seems that the triple therapy works better in patients with high volume disease according to the Chartid criteria. And this has been recently summarized in this meta-analysis showing the highest benefit indeed of a triple therapy approach is for those with de novo metastatic hormone-sensitive disease and high volume disease. We all know that oligo or recurrent disease after surgery is a different story. The outcomes are really better than de novo disease, so these might not, of course, be applicable to those patients recurring after surgery or after radiation therapy that's been like minimally included in these studies. Indeed, the guidelines suggest or recommend the use of triple therapy. So these are the updated 2023 EU guidelines suggesting or recommending the use of triple therapy in patients fit for docetaxel for sure, mainly with high volume disease. But we are going a step further, and we want to know whether additional treatment intensification makes a difference. And this study that we all know, which is the PEACE-1 study, which randomized patients into 4 different arms, and this study actually also included 2 arms with patients receiving or not radiation therapy to the primary. This study has not yet been published, but it will be published soon, presented at ASCO. There was a lot of noise behind this study. It's a great contribution, and pretty much it showed that additional radiation therapy together with intensified systemic treatments makes a difference in low volume disease, but not on overall survival, maybe for the low number of events. It's mainly a benefit on radiological progression-free survival and time to CRPC. But there was also a trend or a significant advantage of treating the primary, even in a high volume setting, as long as additional treatments for the primary was concerned. So it seems that giving radiation therapy to the primary, even in a high volume disease, has a sense, at least to decrease the number of side effects or local side effects given by the disease when it progresses. Lastly, a couple of slides about novel approach in metastatic CRPC. Dr. Agarwal, we actually give a keynote lecture on that, so it's really a brief mention on the fact that indeed we are testing more and more early use of PARP inhibitors, and this is already included in the guidelines, by the way, but actually this is coming from 2 main studies. One is the PROPEL study, which has just been updated in its long-term outcomes, assessing survival, which was not reached as a secondary endpoint, but still there was a benefit in patients with metastatic CRPC, all comers regardless of the HRR mutation status, with first-line treatments after progressing on ADT, and there was a benefit on metastatic progression-free survival. The scientific debate here is whether all patients are benefiting from this approach or we should select only those with mutational profile. And this another study, which of course will be mentioned in the next talk, is the TALAPRO-2 study that again showed that as a first-line therapy metastatic CRPC, using a PARP inhibitor makes a sense and might indeed improve patient outcomes in terms of further progression. So having said that, I think that it was all what I wanted to say in terms of novelties of the prostate cancer published on the last year. Yesterday was a fantastic evening, and this was just a picture of the great dinner we had. Thank you very much.
I'll be excellent as usual. Thank you so much. And I am particularly happy to introduce our host today, Andrea. Several years ago, myself and the entire group I have the honor to lead did fight to have Andrea coming over to San Raffaele and be a professor at our university. I think that that was the smartest move that we have done as a group over the last 10 years or so. We have developed a very strong alliance between ourselves urologists and the medical oncologists led by Andrea. So I'm particularly happy that you're here giving this talk. Congratulations for putting together this massive number of top thinkers in the area. So Andrea, the floor is yours.
Thank you, Francesco. Thank you, Professor. Welcome, everyone. Good morning. I'm really happy and cannot be more happy to be here and to see so many friends here. So first of all, I have to thank you for coming here. In particular, the international faculty. You did a very long flight, okay? You have some jet lag, but I hope you will enjoy at the end the journey and the day. Some housekeeping very briefly. So we'll have breakout sessions in between the sessions, but please grab your coffee or your food very soon, because during the breakout session we will have the patient advocate spaces. So palinura first, bladder first, antura second, and prostate cancer, Europa Uomo the third. And you will enjoy discussing with friends from the patient advocacy groups who will present you the activities that are ongoing in Italy in bladder, prostate, and renal cell cancer. So please attend this session because they are very, very important session. And lastly, please do not forget that we have a streaming online with YouTube today. I know that there are many patients of ours that are attending this session. So I have to thank, first of all, the patients that are attending. A few of them are already here attending in person. And all of these achievements, I can say, are all addressed to them, are dedicated to them, and the advances that we'll discuss in bladder cancer in this case are dedicated to them in principle. So 2023 has been clearly the year of bladder cancer. So many things, so many new therapies have come to the ground of potentially available therapies worldwide. So we will navigate very briefly throughout the clinical stages and present to you the key studies, the key trials that made difference, a huge difference in the treatment, the paradigm change in this patient population. So let's start first with the advanced disease, metastatic disease, because the major changes here and the major cutoff here is set by the ESMO 2023. There is the pre-ESMO 2023 and the post-ESMO 2023 era, clearly, in the metastatic setting. So let's start first what was available and is still available today in daily practice for patients with metastatic disease. In front line in European Union, we still have chemo backbone, cisplatin chemotherapy or carboplatin chemotherapy as a standard of care, followed by maintenance of avelumab. This is still the standard of care available in routine practice in this patient population. A lot of other...
Andrea, we have an issue with the slides that they are taking care of.
Oh, I'm sorry.
Because you see those advancing,
here,
but not in the main screen, you see?
I'm running here, let's see. Let's see. But the PC here is working. Maybe there is some disconnection. I just found that in my pocket a good way to start and to interrupt or to interrupt excess amount of questions. This is my tool that I found in my pocket. So we will use it during the session to stop you if you exaggerate in making questions. But please feel free in principle to intervene and to make comment. Let's make the presentation very friendly. At least mine, or there are many more inciting presentations afterwards. Is it running? Okay. I have to use this one? Or I can use this?
It's better, this one.
Okay, now it's working. So the pre-ESMO era is clearly made by chemo and available maintenance therapy as the backbone therapy. We had attempts to improve the outcomes in front line, combining immunotherapy with chemotherapy. And we have 3 major phase 3 trials that failed to achieve the primary endpoint of improving overall survival or progression-free survival in these patients. IMvigor 130, Danube study, Keynote 361 failed to achieve an improvement by adding pembro, atezo, or combining immunotherapy versus backbone of chemotherapy. But we did have the data of Javelin with the maintenance sequential therapy with immunotherapy. The point is that we clearly lack biomarker approach, And we failed to achieve, to identify a suitable biomarker to use in daily practice. The TNB, I will not spend any words on this because we have an outstanding lecture afterwards by Jeff, which is entirely focused on TNB, and then TNB story. He will build the entire TNB story in GU cancer, so you will enjoy his keynote lecture. The Javelin data are shown here, so clearly an improvement in overall survival. And there are trials that are running in 2 different ways. On one side, we are trying to intensify the maintenance therapy in patients with higher risk disease on the left side, like the Javelin bladder medley, which is combining various therapies as a maintenance therapy after chemotherapy. On the right side, you see the opposite strategy, the strategy of de-intensifying therapy in patients with more indolent disease, less aggressive disease, trying to reduce the number of chemotherapy cycles, so anticipating somehow the initiation of maintenance avelumab. But actually, the big deal here was ESMO, the ESMO meeting, the data that came from the ESMO meeting. Let's start first with the Nivo chemotherapy data. Nivo GEM-CIS, in this case, it's the Checkmate 901 was a study dedicated to cisplatin-eligible patients. So the backbone therapy here is cisplatin-based chemotherapy. Nivo GEM-CIS followed by nivolumab maintenance versus GEM-CIS, the standard of care. You remember the negative trials with Pembro and Atezo, trials that were including carboplatin and cisplatin population. Here we are focused on cisplatin population alone, a randomization 1-to-1. The primary endpoint was met in this study, an improvement in significant improvement in overall survival with an hazard ratio of 0.78. The primary endpoint, the co-primary endpoint of PFS was also achieved in this population with an hazard ratio of 0.72. So again, a positive signal, a level 1 evidence, right, in this study. What is interesting in this study, I think, is the rate of responses, and in particular the rate of complete responses is pretty high in the Nivo GEM-CIS population, 21.7%, and in particular the duration of complete responses that was quite huge. The median duration of complete responses is 37 months versus 13 months with chemotherapy alone. So this is something to investigate more, and in particular subgroup analysis and the secondary analysis that we follow to this trial try to identify the characteristics of the population who achieve the complete response and maintain the complete response over time are critical in order to set the scene for this study. In particular, when dealing with and when evaluating this practice-changing study, standing ovation at the ESMO meeting, right? I remember, maybe Alberto, the previous standing ovation in a GU cancer, maybe the taxane study, the Charty study. You remember the ASCO last year, the trastuzumab deruxtecan in breast cancer, standing ovation. Now the second, the further standing ovation was in bladder cancer, for the first time, I would say. The EV302, including all comers, all platinum-eligible patients, cis and carboplatin, EV-Pembro, enfortumab vedotin, and pembrolizumab, compared to chemotherapy, gem-cisplatin or gem-carboplatin. A randomized study. This is the magnitude of effect in terms of PFS. So no words to say, that was a clinically meaningful and statistically meaningful improvement in PFS. And most importantly, I would say, the data that generated the standing ovation here, right? The ESMO meeting, the magnitude of improvement in overall survival, I would say, standing ovation, fully dedicated to the patient, of course, in overall survival. So clearly something that is potentially practice-changing, that will presumably come soon. It is already available in the United States. Hopefully will come soon in our ground, in the European Union. No difference and no signal of differential effect according to baseline characteristics. Effect maintained regardless of cisplatin eligibility, other patients' characteristics, no question about this. But there is a pointer related to the safety profile, of course, which is quite completely different with EV-Pembro as compared to chemotherapy. So maybe that the transition from trial evidence to real world may not be so easy, and the learning curve is still required by oncologists to handle and to manage side effects and to prevent side effects in this patient population. Most of the side effects are unpredictable. This is a point to make when dealing with this patient with the special combination maybe in early disease lines. Of course, there are pros and cons. For sure, patients who have already experienced an EV-Pembro combination frontline are, or could be, quite hard to rescue in the case they develop a disease occurrence or disease progression. So the question now, the focus now is shift to the second-line setting. Maybe the platinum chemotherapy will become the standard second-line therapy in this patient population. And we have on the right side opportunities for still considering nivo and the chemotherapy combination. Also, there are considerations to make related to the affordability of treatments, sustainability long-term by healthcare system, cost, and so on. So we will see what the data and the reality will look like in the near future with the lens projected at the worldwide situation and not just at the countries where there is the forefront of the improvements in clinical trials, of course. So the disparity in the treatment and access to therapy and equitable access to therapy is still a point, and Shilpa will make an important keynote lecture today related to the disparities in access to cancer therapy in GU cancers. Shifting to second line, the Thor study confirmed the role of erdafitinib. So targeted therapy against FGF receptor mutations against chemotherapy. It's interesting to see, and Loriot will come here, another New England Journal paper, right? Testing a new and setting a new standard of care in the United States and likely in the European Union soon, in the patients who have experienced chemotherapy and immune therapy with the tumor harboring any kind of FGF receptor 2 or 3 genomic alteration. Interestingly, when comparing, in the newer data from ESMO, right, comparing erdafitinib and Pembro in immune therapy naive patients, we did not find any major signal of improvement in survival, making pembrolizumab option after chemotherapy still a valuable option also in the population of patients harboring any kind of FGF receptor mutation, which enrich the so-called luminal subtype, cold tumors, so less likely to respond theoretically to immune therapy, but as a matter of fact, Pembro performed quite well in this patient population in reality in clinical trials. So Pembro, again, here is a viable option as second-line therapy in this patient population. So I borrowed this slide from Petros, setting the scene of new therapies maybe in the near future, provided that all these therapeutic options will be available at the country level. And it is the major issue of today practice. And of course, a lot of other issues may arise regarding eligibility to EV, failure to EV, rescue patients, and so on. So let's jump first very briefly to the early disease setting. Please don't forget the fact that now in metastatic setting there are a few important points to make in research. First, the issue of overcoming resistance to ICI, to immune therapy, and we will have soon the lectures by Eugen Leo and other friends focusing on the point that we are making, on the effort that we are making in patients who develop an immune therapy refractoriness or immune therapy unresponsive disease, what is going on in clinical trials. And the other point is the molecular testing for FGF receptor, in particular in bladder cancer. And we will have the session dedicated to NGS testing in this afternoon, led by our rising stars, that will try to make any kind of recommendation altogether in the molecular testing in bladder cancer. So for sure, on the right side, please don't forget the fact that the vast majority of the patients worldwide are still out of the potential trial inclusion, are still unaware or out of these possibilities. 84% in a survey made by World Bladder Cancer Patient Coalition, right? So we are still dealing with a small part of the overall patient population. In muscle-invasive disease, the most intriguing developments have been made in the way we can avoid radical surgery in patients achieving an outstanding response to neoadjuvant therapy. And Matt Gasky was the leader in this field, providing the first evidence with the trial that he led in the United States and published a few weeks ago in Nature Medicine, whereby patients receiving GEM-CIS-NIVO and achieving a clinical complete response by MRI, cystoscopy, cytology, were offered the possibility, and it was a patient decision, random allocation right, to undergo radical cystectomy as a standard of care, or to avoid the radical cystectomy and to start a maintenance therapy with nivolumab. So a potentially practice-changing study, practice-changing way of dealing with these patients, of improving the flexibility in the way we treat patients. And this is also the way we are currently making the decision, and we are currently amending our trials. These are the outcomes that are suggesting that for patients opting for active surveillance or maintenance nivolumab, there is still an opportunity for continuing therapy. Lastly, the point that the advances that we made in non-muscle invasive disease, BCG unresponsive disease, CIS mainly, with the use of TAR-200. The TAR-200 is a novel way of delivering intravesical therapy, in this case intravesical gemcitabine, intravesical chemotherapy, and the TAR-200 has been evaluated in a big Sunrise-1 study in cis unresponsive disease. The first results of this study have been presented at the UA this year, and the mature data presented this year at ESMO with the TAR-200 monotherapy in BCG unresponsive disease showing higher than 75% complete responses in this difficult-to-treat patient population. So a potential new way of changing the field and changing the scenario and the way we treat patients who develop a BCG unresponsive disease. And the duration of these responses seem to be quite challenging and quite compelling. And most importantly, lastly, the possibility of charging this silicone tube that they put into the bladder, charging with targeted therapy, not just chemotherapy. And TAR-210 developments and TAR-210 is a way of delivering intravesical erdafitinib in patients with FGF receptor-driven tumors, FGF receptor 2 or 3 genomic alteration. And we have a very initial data presented at ESMO this year in the BCG refractory population with TAR-210, showing that the recurrence-free survival is quite compelling also here. Very small numbers, and we have Johnson & Johnson people here. We are very excited to working with them. Very compelling data, and we will see if this is the newer way of delivering therapies, and maybe in the near future delivering ADC or delivering newer therapies, and going up and up to the upper tract disease and to the ureter and to the renal pelvis maybe. And there are trials that are running in the United States nowadays. That said, I would like to thank you for your attention. I would like to express my sincere thank to all the people working with myself, in particular to the young team. We will hear from most of them here. We have Rising Star session right this afternoon, right? And most of these people have already been granted the major awards like Merit Awards of ASCO. We have 4 Merit Awards of ASCO here presenting less than 35 years old. And the clinical team that is growing up and is hugely collaborating with the urology and the radiation oncology and pathology and all the rest of the outstanding organization. Thank you so much.
Umberto Capitanio and discussing kidney cancer issues. Umberto also has been a medical student, resident, fellow, staff member, and in the early future, professor at this university. He is the vice chair of the EAU guideline group on kidney cancer. And so, Umberto, welcome. The floor is yours. We're happy to have you here with us.
Professor Necchi for organizing this fantastic meeting. Last year was a great success, and actually it's a huge honor to be part of the team, and I'm looking forward also to hearing all the presentation today. So what do we have learned in the last 1 year in terms of renal cancer? When I was preparing this presentation, I thought, which is the sentence that can summarize what we have learned in the last 12 months. And what came to my mind is this sentence, that therapeutics dogma should be always challenged. And actually, this was true for all the clinical scenario. So surgery, imaging, radiotherapy, and also medical oncology. I have few minutes, so I just want to pick up some of the papers that were published this year to demonstrate that therapeutics dogma should be always challenged, and this year this was done for all the clinical settings in terms of kidney cancer. First of all, this is the only paper from San Raffaele that I'm going to show you, but we are very proud for this because actually this is gonna be changed in the next guidelines in January, and is the fact that we clamped the pedicle during the partial nephrectomy, and the dogma was historically that off-clamp strategy preserves renal function. However, off-clamp, that means do not clamp the pedicle, obviously increases the risk of bleeding, complications, and so on. So what we have done was to test the hypothesis that the renal function in patients with normal preoperative renal function actually is not affected by the clamping time due to the fact that the ischemia time that we are able to provide in 2023 are usually few minutes. And what we demonstrated and published is that actually that was the case. So no benefit in terms of renal function, and more complications, more bleeding, more transfusion. And this actually created like a Twitter storm, a lot of social media comments, because obviously that was a dogma in terms of surgical approach. And what we have done in the last weeks was also to create a multi-institutional consortium with the US, Asia, and European other institutions. And what I think is very interesting is that the same concept was also found when the patients with solitary kidney were considered. So again, no benefit in terms of renal function, but increased complications, bleedings, and the dogma actually was belied. So off-clamp strategy does not preserve renal function, except for very few cases, and increases bleeding and complications. And again, this will not be recommended anymore in the guidelines in January 2024. The second clinical setting is imaging. The historical dogma was that imaging is inaccurate for tumor characterization. There were several papers published. This is just one of the examples coming from some Urologic lab in the UK. So we are talking about the TracerX consortium that many of you know regarding especially translational research. And where they analyzed more than 100 patients with the radiomics models to predict 20 target variables and to predict specifically molecular, histopathological, and clinical characteristics of the patients. And many radiomics features were analyzed and computed using pyradomics. Many features were considered. Obviously, some of the things that they were able to predict are something that we can predict also with standard imaging, for example, the presence of necrosis within the tumor. But what I found very interesting is that according to these radiomics features, we are starting predicting also some interesting things, for example, the presence of sarcomatoid features that we know that has major clinical implications in terms of prognosis, but also the choice of the best drug that we can deliver to the patient. And also genetics alteration, for example, the prediction of the loss of 9p chromosome that is again associated with prognosis, but also to the clinical decision for that specific patient. And finally, also histopathological features, for example, the presence of microvascular invasion. So again, a second dogma was belied, and now novel imaging strategies and radiomics are more and more accurate in tumor characterization. The third setting is radiotherapy. You all know that renal cancer is thought to be radio-resistant, but this was probably with the previous technology that we were used to use with our patients. This is one, I think, of the most interesting paper published this year in European Urology. This is a paper, is a phase 2 trial with many also translational findings and implications. They included in a trial patients with a biopsy-confirmed radiographically enlarging RCC, but up to 5 centimeters. So we are talking about organ-confined disease that usually are treated with a partial nephrectomy. And they delivered either 3 or 5 fractions of SBRT, and the primary endpoints were 2, the local control defined as the growth of the tumor in comparison with active surveillance cohort, but also some pathological features. From a clinical point of view, it's evident that SBRT can control tumor size, tumor growth. Many lesions actually also decrease the tumor size. But again, what I found very interesting is that we had also the confirmation in a pathological report of biopsy of the lesion after SBRT, after 1 year of the treatment, that also the cancer control was optimal. For example, the proportion of hyaluroniation was lower. Also, the expansion of important markers, for example, the CA9 was less evident in a statistically significant way. So we had also a confirmation from a pathological point of view that probably SBRT is becoming more and more important. So again, another dogma that is not anymore in the field. Renal cancer is radiosensitive with the new technology, and SBRT can control tumor growth rate with minimal toxicity. And probably, and already there are many ongoing clinical trials comparing this kind of approach to the standard, for example, partial nephrectomy. And unfortunately, from a urological point of view, but probably this will become the standard, especially for example, in the frail and elderly population. Finally, the last topic is the med-onc. Obviously, there were so many important randomized clinical trials comparing new drugs with the standard of care. We are going to talk also during other session about the details of these studies. What I want to focus is only the last dogma that I'm talking about, that there is no indication for adjuvant therapy after nephrectomy. And this dogma actually came out after, I would say, more than 10 randomized clinical trials showing absolutely no effect in giving drug after nephrectomy in patients with no metastatic high-risk renal cancer. However, finally, the keynote 564 was positive. So pembrolizumab in the adjuvant setting confirmed a progression-free survival benefit in all the subgroups. So we are talking about the M1 NED, but also the patients with organ-confined high-grade disease and also patients with locally advanced disease. Why I'm presenting this? Because 2 weeks ago we had also the news release that the same clinical trial will report in January also a positive benefit in all the subgroups, also for overall survival. And obviously this will change completely the management of the patient after nephrectomy. And again, the adjuvant therapy that was not considered in the last 15 years, now we can say that adjuvant pembrolizumab is the new standard after nephrectomy in patients with renal cancer at intermediate and high risk of progression, and this will be included again in January in all the international guidelines. So I'd like to thank you for your attention. It was an awesome year in terms of renal cancer research. Obviously, we have now a lot of things that have been changed in clinical decision and especially in terms of improving the patient's outcomes. Thank you again for the invitation. It was a great honor, and I'm looking forward to listening all the other presentations. Thank you.
Andrea, being a surgeon, I would like you to expand a little bit in front of the audience, which is composed by many surgeons, what we have been discussing together, the two of us, about this new concept of in muscle invasive bladder cancer, doing everything we can in terms of neoadjuvant therapy, and then do everything we can to save the bladder. And my question specifically would be, do you think from an oncological perspective that we as surgeons, we should reconsider the first surgical step? It has always been a TURBT. And in the past, we tend to say, make the diagnosis. It is not necessary to remove everything because we just want to demonstrate that it is muscle invasive. Now, should we change the way to look at things and perhaps do all we can to clear the bladder as much as possible? Then you guys do all the treatments, and that perhaps we can save the bladder. So what are the opinions among the medical oncologists?
It's basically a very, very practical decision that we made, right? So it's guided more than by science, I would say, by practical reasons. First of all, the patient and the patient concerns about receiving a radical cystectomy in the case they achieve an outstanding response. So it's a natural consequence. They obtain the complete response with MRI or CT scan. They sit in front of you and say, okay, why doctor I have to remove my bladder? It's a very, very basic question. We have patients here, and I know there are patients here that made the same question to me, to myself, to you. So the flexibility and the ability for us to be able to provide them with the reliable answer to this question is the right way to design the next generation of clinical trials. So Medgalski started first a few years ago with this type of concept, and they demonstrated that it is feasible. Of course, what is lacking here, the piece in the puzzle that is still lacking is the consensus on a definition of a clinical complete response. You mentioned, of course, the TURBT. It is part of the definition of a part of a way of a tools to use to define a clinical complete response. I suspect that by adding to the theory and to the trial by Medgalski, we should add additional biomarkers, in particular the ctDNA and the liquid biopsy that is able also to provide the context of the systemic therapy response, systemic disease response added to the local disease response to the treatment, and provide the patients with a reliable opportunity to save the bladder and to be cured and saved by maintaining the bladder. I think, and I suspect that Petros has some word to make. We discussed a lot at the IBCG meeting this summer and within trials on how can we make a decision and how can we define clinical complete response, right? We will hear from Lars the advances in the field of ctDNA testing. It is, to me, of paramount importance in this path. Petros, what do you think? In the same path, it is also something that I suspect also is affecting your current practice when you are discussing with your surgeons, right?
Andrea, thank you so much for inviting us, and Professor Motorsi, thank you. Great question. Thank you for inviting us. Great point, and I think the field is rapidly evolving. Right now, I think we're at this edge where we're conducting the trials to test the hypothesis, whether we can safely save the bladder and have an acceptable long-term outcomes in selected patients. I think we're not there yet in standard of care. I think we're having the first success with Dr. Galski, Hoosier Cancer Research Network trial that you saw, Andrea, that in a notable amount of patients, this can be achieved. The trouble is how to select those patients, and we're trying to develop biomarkers. I think ctDNA enlarges here is the most promising biomarker. I agree with Andrea. We saw data from your studies, Andrea, Puro-1, data that large generated, and from Abacus that this is probably the most promising biomarker. I think it's a prime time to test the hypothesis and continue those trials. There's a trial in US by the Alliance Group with Gopa-Ayer. There is RETAIN-2 in FOC-Chase. And in the future, with more trials, I think we're going to test the hypothesis even more. I think one of the key aspects is what you discussed, Andrea. We need to define clinical complete response, and in a particular trial, have a clear definition of it, and then give scenarios and options to the patients for bladder preservation or not, and try to follow them over time to have adequate follow-up to ascertain the correlation between clinical complete response and event-free survival, which I think will be the link to consolidate. And to Dr. Montorsi's point, I think the maximum TURBT is a major confounder, right, in terms of pathological complete response in cystectomies. That's why the FDA wants a time to event endpoint as a registrational pathways for neoadjuvant trials, because it can impact, significant amount clinical complete response and pathological complete response.
And the question to the surgeons here, following the question by Professor, related to the need maybe to consider a radical or maximal TURBT when dealing with this kind of strategy. Do you think that is it a reliable strategy so we can change our mind and making consideration of doing a re-TURBT also in patients who are candidate for systemic therapy, not just chemoradiation? Maurizio?
First of all, thank you very much for this invitation. I'm a surgeon, so I was tackled this point of TUR. I think that complete TUR is very important. It's always been important. And one of the major things is to detect CIS, which is not so frequently done. In fact, if you take a sample after radical cystectomy, it is coming from Spain, from Joan Palou. You can find CIS in more than 50% of the patient. So we are not able to detect it. And this is a negative prognostic factor we have to consider beforehand. So I agree completely. We need a biomarker in order to decide to preserve the bladder or not. However, I really think that a very important TUR, a complete TUR, to reach T0 is extremely important. So I am with you. So
very quick question to you, then we will come to Arturo with a question. Provided that you have a patient who has undergone the maximal TURBT, having been diagnosed with the T2 stage, right? So in muscle infiltration, you stage this patient with the ctDNA and you find a ctDNA negative test. So you have a potentially radically resected disease and a negative ctDNA test. Would you be in favor of dealing with or providing this patient a systemic therapy, any neoadjuvant therapy in this patient? This is something that we are experiencing today, right? When implementing ctDNA test at baseline and after systemic therapy, when we see, okay, after the TURBT, prior to starting systemic therapy, we found a ctDNA negative test. I personally am very much scared of providing systemic therapy, potentially toxic systemic therapy in this patient population.
My answer is, we have to remember that if we have muscle-invasive disease, T2 at least, a certain percentage of patient has already metastatic disease in the node. So maybe 20%. And I think we have to think about this systemic therapy also in this patient. Very simple.
Arturo, please. Do you need a mic?
No, thank you, and congratulations. This morning we have really enlightening presentation. I, of course, would like to focus on imaging. I'm an imager. And I would like to comment what Umberto showed us. First of all, I want to congratulate because the way you designed your presentation was great. So trying to always think about what is our practice is good. So you're mentioning that in imaging, radiomics is going to be a game changer, which is partly true. So we know that some of this study, they might be underpowered because they don't have a strong comparison with the external testing. But anyhow, I would like to add that so far, from my point of view, a real game changer is going to be the use of targeted radiopharmaceuticals. So particularly for renal cancer, we now have CA9, radiopharmaceutical targeting CA9 that would be able not only to differentiate different tumors, so trying to characterize different tumors, but also, and going to the third part of your presentation, also putting us in the position of doing targeted radiotherapy with these radiopharmaceuticals. So I just wanted to integrate what you say. Thank you very much.
Thank you, Professor, for your comment. Actually, you are completely right. Actually, you also anticipated my presentation for the next year, 2024, because the ZIRCON study that actually was the clinical trial that demonstrated what you are talking about is actually not published yet. So I completely agree with your comment. I decided not to include that specific part because we want to see the full paper published, to see more in a, I would say, more accurate way the sensitivity, specificity of the trial, because that trial is going to have also implication for what you are saying. So also the use of theradiagnostic part of the treatment. Until that paper is not published, I agree with you, is going to be a game changer, probably not today, but probably tomorrow. Thank you for your comment.
Right, guys, because we may extend the same question to Neeraj. You have to tell me what is for you the right patient population to invest on in renal cell cancer and in prostate cancer when trying to design neoadjuvant trials. So the advantage in bladder cancer is that we have a shared model, the T2, T4, N0, M0, muscle invasive bladder cancer is a shared model in the community, right? To design trials in a neoadjuvant therapy. What about renal cell cancer, for example? We have a very huge heterogeneity in the published data in the terms of patient population, disease extent, disease characteristic, and so on, and the same for prostate cancer. So in a few words, what is for you the best patient population you would invest on when by providing systemic therapy prior to any major surgical consideration?
Start, Roberto?
Yes, please start.
Okay. For clinical cancer, actually, is pretty easy because, in terms of neoadjuvant, if you mean to give at least one dose of drug, we have the PROSPER trial that actually is considered an adjuvant trial, but actually with the starting of the drug before nephrectomy, and that allowed also to have implications in terms of analysis, for example, of the pathological reports and so on, was a negative trial. Then we have many other neoadjuvant trials that explore the hypothesis that this may be useful before nephrectomy. However, in clinical cancer, I would say that the major setting of interest is the patient with already metastatic disease, where the patient received the first line therapy, and then the decision is to add or not the multimodal surgical aspect. But in terms of a pure neoadjuvant in organ-confined disease, unfortunately, at this time, we don't have many useful information.
So you don't see any at the medium short term, you don't see any major opportunity here in patients with a localized disease to invest on multimodal therapies, right?
According to what was published, I would say no.
Okay. And what about prostate?
So I think it's in prostate cancer, as you know, we have tested in several studies the role of neoadjuvant therapies with overall, being very frank and honest, very disappointing the results. We are all waiting for the Proteus study, which is using ADT plus apalutamide in some patients with high-risk disease. But I think we should change our mentality and approach how to give neoadjuvant therapies in prostate cancer. So if we stick to the classical definition of risk groups or patient risk classical stratification, I think that we fail. So what I envision for the future is a real platform, and that we can build upon each patient profile according to mutational status, immune infiltration, and PSMA expression. And this platform is actually the real challenge for the future, and we hope that here we can embark in such a great protocol where you can give individualized approaches according to each patient profile. This is something which is nowadays going on in Canada, and honestly not in Europe yet, but the idea is to really individualize neoadjuvant approaches, because there is room for improving patient outcomes with neoadjuvant therapies, but not in all comers and not in the same ways in all patients.
Niraj, what do you think?
I have the microphone, and before Niraj gets to respond, Andrea, to your direct question, it's Jeff here.
Oh, okay.
I just wanted to add, and specific to urothelial bladder cancer, not for prostate and kidney, at least right for now, the issue of whether and possibly likely ultrasensitive blood-based mutation in genomic and epigenomic will ultimately be so reliable that decisions such as bladder sparing, like we spoke about at the International Bladder Cancer Meeting in Houston back in August, could be really useful as making that final decision. Has the blood been cleared of any mutational signal or not cleared, to make the decision of whether to go ahead with radical cystectomy or to be able to continue to maintain bladder sparing treatment?
Regarding the question on neoadjuvant neoadjuvant therapy.
The opportunities in prostate cancer to invest on this multimodal systemic therapies in patients with organ-confined disease.
Yeah. I tell young urologists, this is unprecedented time for investment in neoadjuvant therapy setting. Sorry, my voice is a little down. I don't think we have seen this era. Chemotherapy didn't work. AR blockers really just delay the recurrence, in my view. I think given the unique advancements in bispecific antibodies, CAR T cells, I think this is time to invest on neoadjuvant therapy of high-risk, localized high-risk prostate cancer, utilizing these immunotherapy, novel immunotherapy regimens. And this is where I think the value for the buck we are going to spend will be. Maximum value we are going to get out of it. So, thank you. Yeah.
Maurizio, one last question, and then we will jump to the...
I would like to have a comment from you about a special group of patients more than 80 years old. We heard about nice trials, very selected patients, everything is okay, fantastic. However, the everyday life is different, because the patients we are facing are maybe with comorbidities, they don't want to be treated or something like this. So my question to you is, to you all, is what do you think that you can use the new drug, new therapies in this kind of patients, in this, it's important, because in my experience, at least 15% of patients that do radical cystectomy are more than 80s. So this is a problem. What do you think?
I can tell you from the medical oncology standpoint that we are lucky, because advances in oncology in elderly patient population have been made basically with the use of immunotherapy or immunotherapy combination. So we are targeting, for example, within trials, very frail patient population, like, for example, in bladder cancer patients who are considered as being unsuited for any platinum chemotherapy. And there are trials investing on this. So patients with very advanced age or very poor renal function or very poor performance status. So the same may be, and we are experiencing the same in the neoadjuvant setting. Patients who are very frail or with advanced age may be provided with some kind of a neoadjuvant immunotherapy, and we did so with excellent results. So the field has changed a little bit by shifting the paradigm from chemo to newer, more effective therapies. And I suspect the same would have an impact on surgical decisions.
So if I can make a comment on that, I think you're completely raised an excellent point, and this needs to be taken into account whenever we give indication for therapies. On the other hand, we as surgeons should do a better job in understanding needs and for patients. Geriatric assessments, how many times do we ask for geriatric assessments? Very few. How many times we use the so-called G8 assessment score? Very few. How many times we calculate the real life expectancy of our patients rather than by a chronological age? Very few. So on the other side, the point is very well taken, but on the other side, we should be critical with ourselves and making a better job, including patients in multidisciplinary programs.
No, I think you raised a really important question, and I was just reflecting. I saw a patient 2 weeks ago who's good friends with the head of our radiation oncology department who has muscle-invasive bladder cancer. And the first question to me, he sent him to me for cystectomy. 92 years old, multiple medical comorbidities. Clearly, you take a step back, although he's in perfect physiological age. Clearly, we all understand the comorbidities of doing a cystectomy in that patient cohort. And I think it's unappreciated sometimes. And it becomes very easy to get, into this tunnel vision. You say, as a clinician, you're just going to technically do surgery. You've got to take a step back. Ultimately, what is going to kill this patient? What is in his best interest? And really focusing on their quality of life as much as ultimately what your anticipated outcomes are going to be. And I think we all have to have these multidisciplinary conversations and not necessarily, sort of go on the tangents of just offering a given modality. I think especially with the recent publications with trimodal therapy, we clearly understand there's a significant subset of patients could benefit from this treatment. And I think as was mentioned by Dr. Montorsi so eloquently, I think the TUR is one of the only tools, rudimentary tools we have right now in identifying those patients. Clearly, if they have high volume T2 disease on the rear resection, clearly that may not be necessarily a good candidate for that modality.
Thank you. So we are almost perfectly on time to move to the next session. And I would invite Professor Chiti to come to the stage. Grazie.
Good morning. We are late, but the discussion was very interesting, and so it's very important to discuss each other. This session is dedicated to the treatment of metastatic disease in prostate cancer patients, and it is a great pleasure to introduce Professor Agarwal because he is one of the leading experts in the clinical research. Professor Chiti will introduce the Professor Agarwal.
All of you know very well Professor Agarwal. He is a professor of internal medicine at the Huntsman Cancer Center. Yes. And his main position is to be the Senior Director for Clinical Translation Research at the Huntsman Cancer Institute. And of course, he holds a professorship at the University of Utah. So please, Professor Agarwal.
Yeah. First of all, what a pleasure to be here in such a esteemed institution, recognized all over the world and surrounded by such fantastic, accomplished speakers, investigators. So really honored to be here. And thank you, Dr. Nechi, for inviting me for this talk. My voice is a little down because of allergies, but I think I'll be fine. So my job is to talk about therapeutic advancements in prostate cancer. This is my lifetime conflict of interest. I have no conflict of interest since May 2021. So I'd like to talk about high-risk biochemical recurrent prostate cancer. I'll give my perspective on all those scenarios, in addition to showing the most recent data. And then I'll talk about metastatic hormone-sensitive prostate cancer, doublet versus triplet, and where we are heading in this field. And then, of course, talking about prostate cancer in castrate-resistant prostate cancer setting, and talk about PARP inhibitors and lutetium-177. So let's look at the EMBARK trial first. Dr. Steve Friedland, Dr. Neil Shore presented this trial in AUA, just published in NEJM. Congratulations to them. Background is these patients who have localized high-risk prostate cancer and have high-risk biochemical recurrence, they are very likely to develop metastatic disease in the following 4 to 5 years. So can we do something there? Right now, the standard of care is literally sometimes nothing versus androgen deprivation therapy. Many patients receive intermittent or continuous ADT. So this trial randomized patients to enzalutamide plus ADT versus ADT alone versus uniquely enzalutamide monotherapy. Progression-free survival is the primary endpoint, and we saw metastasis-free survival to be significantly improved with the enzalutamide plus ADT over ADT. Interestingly, enzalutamide monotherapy also improved metastasis-free survival. Overall survival is trending in the right direction. If you look at the side effects, really we don't see much difference in the treatment emergent associated side effects such as fall, such as fatigue, or many other side effects such as hypertension, for example. However, uniquely, gynecomastia or nipple pain is a lot more common in enzalutamide monotherapy arm. And I think patients who are pursuing this treatment will have to be treated with prophylactic radiation therapy early on during the course of disease. Sexual function was slightly improved with enzalutamide monotherapy arm. So what is my take on the EMBARK trial results? Yes, enzalutamide improves metastasis-free survival. Overall survival is trending in the right direction. Side effects are very similar, except gynecomastia and sexual function or dysfunction is improved. So many of these patients, as is already been discussed, many of these patients have PSMA. If they get PSMA PET scans, they will have metastasis. So in my view, these patients now can get enzalutamide early on without having to wait for onset of metastasis on the conventional bone scans. For true biochemically recurrent patients, in my view, enzalutamide monotherapy will be highly attractive. I already have patients who really do not want to be castrated indefinitely so early in their disease. And enzalutamide monotherapy will allow them to have this treatment where they can easily take a break and resume sexual function, for example, within 4 weeks. Or they have literally better control on how they want to be living their lives. So I think enzalutamide monotherapy, if approved, will give an opportunity to our patients to avail this therapy without castration. So I think these are the takes on EMBARK trial. So let's move on to metastatic hormone-sensitive prostate cancer. So this is the evolving treatment landscape. We have seen literally a revolution in the treatment modalities in the metastatic hormone-sensitive prostate cancer, and these are the stalwarts which have led to availability of these drugs for our patients in our clinic. So this is a summary of this metastatic hormone-sensitive prostate cancer trials. This is amazing to see the hazard ratio, literally consistent hazard ratio across the trial as far as reducing or reduction in risk of death is concerned. 0.35 or like 0.66, 35% to 30% reduction in risk of death across these trials, whether you use enzalutamide, abiraterone, apalutamide, we see very similar results. So all patients seem to be benefiting. So if you look at, I just took the example of Titan trial and the Arches trial as an example. And we see all these patients seem to be benefiting, regardless of high volume, low volume, Gleason score, high Gleason score, low Gleason score, performance status. One group doesn't seem to benefit. And this is patient with visceral metastasis. When you look at visceral metastasis, I'm really talking about liver metastasis, which is present in 5 to 7% patients with newly diagnosed metastatic prostate cancer. So really, when I am contemplating treatment for our patients with metastatic hormone-sensitive prostate cancer, this is the group I really want to do something different. Now, let's look at the triplet therapy trials. These two trials were presented recently, and this is the design of the trial. And the bottom line is ADT plus docetaxel plus ARPI were compared with ADT plus docetaxel chemotherapy and showed improved survival. Overall survival was improved, and progression-free survival was also improved in the PEACE-1 trial. There's no doubt, compared to ADT plus docetaxel. So this is what we have gathered from the triplet therapy trials. And I know Dr. Briganti talked about triplet therapy versus doublet therapy, what drug to choose, or what should we choose in our patients. Really, we have not shown that de novo high-volume metastatic prostate cancer patients do not benefit with ADT plus doublets. We have not shown that yet. So far, all we know that triplet therapy is better than ADT plus docetaxel. However, we have not answered this question, that ADT plus ARPI plus docetaxel is better than ADT plus ARPI. So my contention is that if I see a patient with visceral metastasis up front, or maybe patients with tumor suppressor gene loss, I do comprehensive genomic profiling on all patients, so if I see RB1 loss, B10 loss, P53 loss, at least 2 of them, or visceral metastasis, 20% patients, I really want to use triplet therapies, but most patients do just fine with doublet therapies. So question is, how do we know? How can we personalize medicine? So these are the 3 studies. The first is from Latitude trial, and second from our Titan trial, and the third is from the SWOG 1216 trial, only trial which was negative in hormone-sensitive metastatic prostate cancer, unfortunately. But we gathered a lot of great information from these trials. If you look at the PSA responses early on, so if our patients do not experience a PSA response of 0.2 or less, they are in trouble. We just published the data from our own institution. Patients who do not experience a PSA response of 0.2, the median survival was 38 months, versus patients who achieve is not the right word, it means patient's fault. Patients who do not experience a PSA response of 0.2 or less, or who do, their survival, in my estimate, is going to be around 80 months. So I'm looking forward to presenting our data in GU ASCO on Titan trial on long-term responders of these patients. And I can tell you right now, without disclosing the data much, that we are going to be seeing unprecedented survival in these patients. So we really want to ask ourselves, is triplet therapy, giving docetaxel to these patients who may have these fantastic responses, worth it? Or should we just keep those side effects for later use? Can we use some other therapy? Can we use some other biomarkers? So before I go to those biomarkers, I want to really highlight these fantastic trials which have already started, de-escalation trials based on PSA responses. So PSA response happens if we see PSA of 0.2 or less. As I said, these patients are going to be living for decades. I'm working with cardio-oncologists more actively than ever because we know cardiovascular causes of death will exceed prostate cancer-related mortality in these patients in the near future. We are going to see that in the next 5-6 years. So what can we do to de-intensify? So reduce the risk of long-term ADT. And these are the trials which have already started. So these are the 3 trials. First of all is the de-escalate trial by Bertrand Dr. Tombo in EORTC. Second is A-DREAM trial being led by, this is an alliance trial by Atish Chaudhry in alliance. And we have started this Libertas trial. Again, this is a phase 3 trial where patients who achieve a PSA, who experience a PSA level of 0.2 or less, we will drop ADT in those patients. Can we use biomarkers? So we published this study with SPOP mutation. Patients who have SPOP mutation, and this was a study published in Clinical Cancer Research by my colleague in Huntsman, Dr. Umang Swami. And these patients have prostate cancer which are addicted to androgen signaling. And they have remarkable responses to ADT plus ARPI drugs. On the other side, patients who have P10 loss, P53 loss, RB loss, they don't seem to be benefiting much, and they may be requiring chemotherapy with docetaxel. So should more treatment be based on biomarker? And I think we are going to be seeing an unprecedented era of personalized medicine in metastatic hormone-sensitive prostate cancer. And we are doing these multiple trials. The first one is TALAPRO-3 trial, utilizing enzalutamide plus talazoparib in hormone-sensitive setting. Second trial we are doing is Amplitude trial, where patients are going to be treated with abiraterone plus niraparib if they have HRR mutations. We are eagerly waiting for the results of CAPItello trial with PTEN loss, where AKT inhibitor is being used for these patients. And of course, PSM addition trial, where high PSM expressors are being treated with lutetium upfront. So this may be the time which will be happening very soon in our clinics. We'll be showing this picture to our patients and talking about really personalization of medicine, whether we are going to be intensifying based on PSA responses, whether we'll be de-intensifying based on PSA responses, or using these molecularly targeted therapies. So what is my take on hormone-sensitive prostate cancer treatment? There is no role of ADT, except in those patients who have median life expectancy of less than 2 years. Doublet therapies, in my view, are applicable to vast majority of patients. We should not really be offering triplet therapy over doublet therapy, because there has not been a randomized trial showing triplet therapy is better than ADT plus ARPI. We need biomarkers, and given increasing overall survival, which is a fantastic news for our patients, we need response-based biomarkers, escalation and treatment strategies for our patients.
Excuse me, Professor Agarwal, we are still with this problem.
I'm sorry.
So,
yeah.
Is there any? No, okay.
Yeah.
No, now it's working. Okay.
So this is the summary of my take on treatment of metastatic hormone-sensitive prostate cancer. And fortunately, for the first time, we are seeing de-escalation strategies to be utilized for our patients who have a great PSA response in first 6 months. So let's go to the castrate-resistant prostate cancer. Before I go to CRPC, we often hear that patients who have never been exposed to NHT do not exist in the mCRPC setting. We are going to be presenting the data in AUA, showing that vast majority of patients with new mCRPC in the US have not been even exposed to novel hormonal therapy. And I cannot tell you the figures exactly. Let's wait for the AUA meeting. But I really want to highlight and bring your attention to pathway to onset of mCRPC. At least in the US, vast majority of patients with prostate cancer are diagnosed with localized prostate cancer. They have biochemical recurrence. They are treated with ADT or intermittent ADT. And slowly PSA starts rising. And when they have conventional scans or PSMA PET scans, they are found to have mCRPC. We also heard from Dr. Briganti's talk that there are patients who are going to be receiving abiraterone for limited duration, 2 years of abiraterone. Do you think their testosterone will ever recover after receiving 2 years of abiraterone plus 3 years of ADT? I have seen at least 4 patients in last 6 months who received limited duration abiraterone and 3 years of ADT, and they developed mCRPC without disease progression on continuous abiraterone therapy. And all these patients, and of course we know the MHSPC data, most patients across the world, I showed the data in ASCO, even in European countries or US, and I'm not even talking about emerging economies, most patients in the hormone-sensitive prostate cancer are not receiving treatment with ARPI. So in next many years, we are going to be seeing a lot of patients who have not really progressed on an NHT when they get to mCRPC setting. And the next data I would like to bring your attention are the attrition rates. Like many cancers, like almost all cancers, we lose patients from first line to second line therapy. And this is from Flatiron database. We updated these data 2 years ago. Now 10,000 patient data from Flatiron. People who do not know Flatiron database, this is not SEER, this is patient level data extracted from electronic medical records. There's no ambiguity about these data. And we know that half of the patients do not receive subsequent line of therapy. So it is extremely important to intensify medications or treatment regimens. And that is one reason why intensification works in prostate cancer, because we know half of those patients are not going to receive subsequent line of therapy. So let's move on to PARP inhibitors. So what is the rationale for combining a PARP inhibitor with novel hormonal therapy, or ARPIs? We know from preclinical data, and we just published this paper in European Journal of Cancer. This is a free open access paper. Feel free to download all the data, preclinical data, on why PARP inhibitor combination, PARP inhibitor with NHT combination have strong preclinical rationale. So when AR is blocked, PARP gets upregulated so as to rescue these cells from the assault, literally, if you will, by the androgen receptor inhibitors. And when we block PARP, that leads to downregulation of AR inhibitor. So based on the results of study 8, which was published in 2018 in Lancet Oncology, where Dr. Noel Clark and team showed that ADT plus abiraterone plus olaparib improves outcome versus ADT plus abiraterone, 3 trials were started. Unfortunately, the CASPAR trial the accrual has been terminated, so I don't think we are going to see the results, but I'm going to be talking about the first 3 trials. So this is a schema of these trials: PROPEL trial, MAGNITUDE trial, and the TALAPRO 2 trial. And what we saw was, and this is a summary of those trials, what we saw that consistently abiraterone plus olaparib, abiraterone plus niraparib, or talazoparib plus enzalutamide improve radiographic progression-free survival compared to NHT alone. Now there are some nuances here. If you look at the HPFS in BRCA2 patients, BRCA2 positive patients, you can see in the MAGNITUDE trial, the hazard ratio is 0.53. And in the TALAPRO 2 trial and the PROPEL trial, if you look at the, where's the pointer here? Thank you. Oops. I'm sorry. Anyway, I'm trying to point out, maybe I use the mouse. So if you look at the BRCA, okay. So if we look at the abiraterone plus niraparib combination, we can see the hazard ratio is 0.53. With the talazoparib and olaparib combination, hazard ratio is 0.23. I think there is difference. There is a difference in efficacy of abiraterone plus niraparib versus other 2 combinations. And we know we should not be comparing the trials. We should not be comparing results across the trials. But because niraparib dose was reduced by 33%, it is possible that it is compromising the efficacy of niraparib, at least in this setting. And otherwise, these are very similar trials with some nuances that in the TALAPRO 2 trial, the tissue profiling was prospective. In olaparib trial, it was all retrospective. But I personally think, based on these results, these patients who have HRR mutations, and this is my take on PARP inhibitor combinations in MCRPC. First of all, many patients with new MCRPC will not have disease progression on a prior ARPI. There's no doubt. There are going to be patients who are progressing from localized prostate cancer. Yeah. Yeah. So we know that there are going to be some patients who are going to be progressing from localized prostate cancer, patients who have received 2 years of abiraterone, or patients who do not receive novel hormonal therapy in metastatic hormone sensitive. So based on this, first of all, how I select this combination, for new MCRPC patients, for BRCA1 and BRCA2 mutation, really my choice is based on the underlying abiraterone or enzalutamide. So if they are going to be receiving abiraterone, I'm going to use olaparib. If they are going to be using enzalutamide, based on drug interaction, based on copay in the US, I'll be using talazoparib. For non-BRCA HRR mutations, I use enzalutamide plus talazoparib combination. All patients with advanced prostate cancer should undergo tumor genomic profiling and germline testing. There is no question about it. There are medico-legal implications associated with that now. So next step is we have to find out the mechanism of response in so-called HRR negative patients. Because the hazard ratio for PFS was 0.66 in those patients. The signal is real. And we just need to find out who are those patients which are responding. And next step is to find out the mechanism of resistance to PARP inhibitors. So let's move on to the lutetium-177 therapy. And this is the last portion of my talk. We saw the data from the VISION trial. And this is the VISION trial design, where lutetium PSMA was compared with standard of care. And the standard of care was literally bone strengthening agents in half of the patients and novel hormonal therapy in other patients. And these patients had disease progression on docetaxel chemotherapy. They could have received cabazitaxel, and most of these patients, or all of these patients, had to have disease progression on a novel hormonal therapy. And this is the schema of the transformer trial. Sorry, PSMA-4 trial. And we saw that this was just presented by Dr. Oliver Sauter, and we saw that lutetium PSMA was compared with alternate novel hormonal therapy. And these patients had to have disease progression on a novel hormonal therapy. So these are the schema of these two trials. Now, please note that presence of liver metastasis. Do you want to make a guess how many patients had visceral metastasis or liver metastasis in the PSMA-4 trial? 5%. So this is a selected patient population which has high PSMA and were recruited on this trial. And this is the comparison of the data of the VISION trial and the PSMA-4 trial. There is no doubt that the signal is real. This is level 1 evidence favoring lutetium PSMA in both post-chemo setting and pre-docetaxel setting in mCRPC. Overall survival could have been attenuated in the PSMA-4 trial because of 82% patients crossing over from the control arm to the lutetium arm. But there is no doubt that lutetium-177 is a valid option backed by level 1 evidence in our patients with mCRPC. Now I'll bring your attention to these two tweets from Euromigos. So we asked, I was the person responsible for the prostate cancer tweet, so I wanted to see what people, and this is right after the data presented by Dr. Oliver Sauter. And the first question was, this is a patient with high SUV of 25. There's no ambiguity about PSMA expression in these patients. And the first question was, what you would like to treat with next when these patients had disease progression on ADT plus abiraterone and patients had new liver and bone metastasis. 50% patients said docetaxel, 50% patients said lutetium-177, approximately. The next question was, what can you realistically use in the next 1 year? And see, 80% patients are basically saying docetaxel chemotherapy. And this is on X, Twitter. Everybody in the world can respond to this tweet. And this tells us that there are going to be major access issues with lutetium-177. And because docetaxel was not the comparable arm in the PSMA-4 trial, it was not in the control arm, it's possible that patients or doctors may not feel comfortable using lutetium-177 when there is liver metastasis, when there is visceral metastasis. And these are quite common in these patients despite high PSMA expression. So in that context, I will bring your attention to the therapy trial, small trial, 200-patient trial, where cabazitaxel was compared with lutetium-177. PSA responses were better. PFS was better with lutetium-177. Both PSA response and radiographic PFS was better, but overall survival was similar. So what is my take on the lutetium-177 versus taxanes in mCRPC? The first thing, there's no doubt access is going to be a problem for majority of patients in the world. So although lutetium-177 has level 1 evidence in post-docetaxel mCRPC setting, cabazitaxel is an acceptable option in patients with high PSMA expression and should be offered in patients with mCRPC with low PSMA expression. In the pre-docetaxel setting, both lutetium and docetaxel have level 1 evidence. They have not been compared with each other. So it's absolutely fine to use docetaxel chemotherapy, especially when lutetium-177 may not be available. So this is my conclusion on my overall talk on treatment of metastatic prostate cancer. We know that treatment of metastatic prostate cancer has undergone a revolution in the last decade, leading to approval of multiple new agents. Recent additions are PARP inhibitors and the lutetium-177. In the absence of head-to-head comparisons and biomarkers for most patients, and most importantly, access issues, the art of medicine will continue to play a role in selection of these agents and sequencing of these agents. Sequencing is extremely important. I go with intensification if I can, because I know 50% of my patients or patients across the world may not see the next line of therapy. The eventual goal is to maximize receipt of life-prolonging agents while maintaining quality of life. And I think it's time for response biomarker-based de-escalation and escalation trials. So this is my team in Huntsman Cancer Institute, and thank you for your attention, and thank you for patience with my voice today. Yeah.
Interesting and enlightening presentation. So we have less than 10 minutes for discussion, so if there are some questions, Alberto first. Oh, okay. It's okay, go ahead.
So, Silpa.
Excellent presentation, Neeraj. Really great overview of all the therapies. I have a question for you. So the triplet landscape, the docetaxel, novel ARIs have been compared against docetaxel, but they have not been compared against ARI. So are we in a position to say that triplet is not better than just, let's say, apalutamide alone? Because the study has not been done, but we don't know what the results would be if docetaxel was added.
Correct. So triplets have never been shown to be superior to ADT plus ARPIs. And because of that, I reserved triplet therapies where ADT plus ARPI doublets have clearly not showing superiority, such as patients with liver metastasis, 7% patients who are diagnosed to have MCSPC and liver metastasis, very small number. And when I see patients with RB1 loss, and we do sequencing for all patients upfront when we see them for the first time. So RB1 loss or presence of P10 and P53 both. So if I see both P53 and P10 loss or RB1 loss alone or liver metastasis, and these are like 20% patients, I use triplets.
And one more question. Thank you for the answer. So based on the EMBARK trial, do you think if enzalutamide starts being utilized in that setting, even though it's a shrinking space, how will that affect the subsequent therapies, for example, for talapro or other combination therapies? Do you think it's an over-treatment in the BCR space when we have other good therapies when patients need it in metastatic disease?
I think I'm looking forward to long-term cardiovascular safety profile in these patients. But there is no doubt that patients with high-risk biochemical recurrence. Now, you can always argue, Dr. Briganti made a very good point, that these patients will probably have metastasis on the PSMA PET. But this gives an opportunity to our patients to get enzalutamide reimbursed, at least in the US payer system. If you do not show metastasis, you may not get reimbursed for enzalutamide. So enzalutamide can be used now in these patients upfront. Now, patients with true biochemical recurrence, my practice is not to use any ADT until they have metastasis.
Neeraj, you want to go first, please. Ladies
okay.
first.
Thank you. I have a question for you because since I have a radiation oncologist, and you know that radiation therapy is a very effective treatment in prostate cancer metastases, especially in the oligometastatic patients, I would like to ask you if you see a role of radiation therapy in this new scenario of drugs. Also taking into consideration that the mechanism of inactivation of the tumor cells by radiation therapy is based on the breakage of either the single or double strand of DNA.
Fantastic question. I did not spend time on showing the emergence of PARP inhibitors in the context of radiation therapy, but there are multiple trials which are going on. We also know that newer kind of radiation therapy, such as lutetium-177, they have solid rationale to combine with PARP inhibitors. So I think radiation therapy will play a bigger role than ever in the treatment of our patients with prostate cancer. There is another scenario where we are using radiation therapy very commonly, which is oligometastatic metachronous prostate cancer, metachronous metastatic hormone-sensitive prostate cancer. I personally think we should not be using ADT plus ARPI or any systemic therapy when we are using radiation therapy for oligometastatic disease setting. And this provides an excellent opportunity to our patients to delay ADT.
Exactly.
So radiation therapy will have more and more role, in my view, for our patients. Yeah.
And how do you consider the association between radiation therapy and immunotherapy? Last question.
Say that again, please.
Radiation therapy and the combination with radiation therapy and immunotherapy.
I think it has solid scientific rationale, and I have no doubt that we will see radiation therapy to be utilized. There will be new trials using radiation therapy in the context of bispecific antibodies. When we are treating someone, just give you an example of a recent patient of mine, really big bone metastasis, painful metastasis. I'm contemplating getting patient on a bispecific antibody trial or a CAR T-cell trial. I want to decrease the volume of disease before I get him on an immunotherapy trial. And in this context, radiation therapy gives me this opportunity to decrease the disease volume, make the patient asymptomatic before I start them on systemic therapy with the immune therapy, which I know is not going to start kicking in for next 3 months. So I think radiation therapy will have much bigger role in the context of next generation immunotherapy.
But it can increase also the immune response.
We don't know that yet. Yes, potential is there.
Potential.
Yeah.
Please.
Great questions, and I appreciate the comment about radiation therapy, which has an evolving role. Neeraj's fantastic talk. I always learn from you, my friend, and your voice is great, by the way. So 2 questions for you. Number 1, could you comment on the need or no need in clinical practice, and sometimes with the difficulty accessing lutetium PSMA, whether we should or not do concurrent FDG PET scans, concurrently with the PSMA PET scans? And on that note, do you have a preference between gallium or any other like PYL PET scans? That's the first question. The second, if you can comment regarding the need for adaptive dosing of lutetium PSMA down the road with properly designed trials. Congratulations.
Thank you. You are always very kind. So I'm convinced that we have to pursue escalation and de-escalation therapy in every setting. So for example, if we are using lutetium-177 in a patient with metastatic CRPC, and after 2 doses of lutetium-177, you do a scan, PSMA scan, and literally there is no uptake. PSA is down, there is no uptake on the PSMA. What makes us think that patient is going to continue to benefit with lutetium-177? I think this is time to stop treatment in that patient who has like negative PSMA scan after 2 doses and reserve next 4 doses for the time when there is a relapse. On the other side, if I don't see any response after 2 doses, I don't think this is going to work. And I will rather switch to taxane therapy in those patients. So we don't have the data level 1 evidence, but I'm so glad that cooperative groups are doing those trials, and we will have the data in that context. The second question was the PSMA? Yeah. Yeah. So if I see a liver metastasis in a patient, I'm contemplating lutetium-177 therapy, I do PSMA scan first. If there is any ambiguity about the uptake in the liver, I do FDG PET scan. And FDG PET scan, if it shows high uptake of the FDG PET, like if FDG PET is highly avid in liver metastasis, I know that this is likely not going to respond. So the utility of FDG PET, keeping cost factors in mind, is if I do PSMA PET scan, and if I see a not so PSMA avid lesion in the liver or bones, I like to do a FDG PET. If FDG PET is lighting up, if it is showing high expression or high avidity on FDG PET, I have two options, either to use taxane in those patients or give radiation therapy to the bone metastasis, which is not PSMA avid, and then start lutetium-177. So I think FDG PET gives us a very good idea of how many lesions may not respond to PSMA-targeted therapy.
We have the very last question, then we have to close it. I also have some comments, but maybe during the coffee break, we'll talk about lutetium PSMA.
Yeah, so congratulations, this has been a fantastic overview of different treatment scenarios. Let me just take a point on the EMBARK trial. The EMBARK trial, to me, is pretty much showing that treatment intensification matters in patients with oligometastatic recurrent disease, despite being negative at conventional imaging. These patients with late recurrences, short PSA doubling time, has pretty much 90% probability of having positive PSMA PET. So to me, the trial is showing treatment intensification on oligorecurrent disease. But we should be careful here, because if you look at these patients, only 50% received radiation therapy, radical plus radiation therapy. And the risk, if we deliver the message of treatment intensification in these patients, is that we just wait the imaging to be positive, and we miss the window of curability of salvage radiation therapy, which to me is the only curative treatment approach in recurrent setting after radical prostatectomy. And if you look at the data, despite being retrospective, there is even a benefit of giving salvage radiation in patients with high-risk disease at lower PSA level than 0.25. What that means, that if we wait the imaging to be positive, or we wait to give enzalutamide or ADT when there is a late recurrence, we might lose the window of curability of early, timely given salvage radiation therapy.
Those are fantastic points. I agree. Yeah.
So now it's time to conclude this section. We thank you again, Professor Agarwal. And I leave the podium to Professor Picchio, Professor De Cobelli, and Professor Briganti for the next session.